classical MODY and two MODY2 families. Since these families are, and the mutations and the carriers in general population are relatively frequent, we can say that there is a possible scenario that some of the cases can be consanguineous, or some of the cases came from two different families of MODY2, and finally they can have both alleles affected and severe phenotype. But there is another story behind the MODY or GCK PNDM patients. We found one family with typical GCK MODY phenotype, but one individual, the proband from this family, this is why we were interested in this family in general, had real severe phenotype with ketoacidosis at onset and neonatal diabetes. And we found this case over here as a neonatal diabetes caused by only one, on the affection of one allele, not as a regular neonatal diabetes caused by GCK mutations when you have two alleles affected. So we don't know whether these patients had other mutation within unknown gene. We screened all the genes related to diabetes, but we were not able to find any mutation in other genes which can explain this striking phenotype and severity of the heterozygous mutation of patient with GCK mutation. So let me back to another scenario which is even more complicated. So if we have two family members, father and the mother of this offspring, who are heterozygous carriers of MODY2 or glucokinase defect, we have about 25% chance to have the patients with very severe phenotype, the GCK PNDM phenotype caused by allelic deficiency, and we found 3 cases in Poland with this phenotype. This is also very important from clinical point of view because among these patients, as you remember, the phenotype is related to both dysfunction of the beta cell and dysfunction of the hepatocytes. In both these tissues, a glucokinase is a glucosensor. So we need to treat the patients, in this case, with insulin. However, the response and glycemic control in most of the cases will be not satisfactory for us. And for instance, in our cases, average A1C was 10.3, so this is more than 4 standard deviation from pediatric patients with type 1 diabetes. And I know from some personal communications from other groups that they have similar problems. So we are not able to control well the patients with neonatal diabetes caused by biallelic GCK deficiency. So in this case, we can recommend only one method of treatment, as insulin therapy, or recently insulin therapy together with sulfonylureas drugs, which can decrease the dose of insulin and decrease also A1C in just a few cases. Let me go to and share some data on a very rare disorder like GLIS3 mutation, which is autosomal recessive disorder. Diabetes come together with congenital hyperthyroidism, glaucoma, liver fibrosis, and cystic kidney disease. I show you one case from our cohort. This is, I believe, this is 8 on the one among the 8 patients discovered or described in the ward. And this patient had permanent neonatal diabetes, hyperthyroidism, cystic kidney disease, and no liver abnormalities. We found one paper discovered this phenotype and genetic background behind this, and we found mutation which changed amino acid in one allele and frame shift mutation in another allele. So this is the first report of not consanguineous patients with GLIS mutation. Interestingly, in our case, we found that even heterozygotes, they have a lower amount of mRNA for GLIS free. And we go further with this case, and we found that among 23 known or predicted couple-like single proteins, only 10 amino acids are completely conserved, and among these 5 are histidines, and one of them is our mutated histidine at the position 347. So this is the causal mutation, of course, and we found that there is a autoregulation of the expression of GLIS-free in peripheral cells. We screened the patient's lymphocytes for this mRNA level, and this is probably related to these discrepancies in the levels as compared to controls is related, and heterozygotes is related to autoregulation of these transcription factors. Let me back to yesterday's talk by Alessandro Doria, who described the BLK MODY and deficiency of BLK as a cause of MODY. In our Polish cohort, we found a novel syndrome, PNDM, together with unresponsiveness to glucagon. And we found one case with this syndrome, and there is a deletion on the short arm of chromosome 8 where this BLK gene is located. And we found with SNP array a very close strict breakage on this chromosome over here. And we can speculate right now that the cause of diabetes is maybe related to BLK deficiency, but we're still looking for explanation for this unresponsiveness to glucagon. And we found, using some bioinformatic tools together with some in vitro studies in our lab, that this gene can be PPP1R3B, this gene encoded for glycogen synthase activating subunit, and hepatocytes which are lacking of PPP1R3B have low amount of glycogen. So this is maybe the explanation why our case or our patient not respond to glucagon well. And this is all what I would like to say about neonatal diabetes right now. I know that this topic is very complicated. There are definitely more and more players on the stage, and definitely we need to play with these patients, because these patients have some very important clinical management options. Thank you very much.
Wojtek, thanks a lot for this excellent lecture full of new scientific data. We have some time for discussion. Please, are there any questions from the audience? Tomek?
So I'd like to ask you about this patient with PNDM and who is a carrier of just one allele of GCK. Did you exclude other reasons for PNDM other mutations in other genes in this case?
Yes, actually, we screened all the genes for MODY together or monogenic diabetes. Yes, and we are not able to find any mutation in these known genes. So this is probably, we can just speculate that this case has another mutation with unknown gene, but this is the only explanation for us.
Any more questions, Professor Mlynarski? Alessandro.
Are there other traits in the patient with a deletion, in addition to diabetes? You know, a huge deletion, one would expect some other phenotype.
Yes, as you know, in this critical interval, there is a GATA4 gene, which is responsible for some congenital heart defects, and this patient had a congenital heart defect. This case is under the patient is after the operation and as well, and no other symptoms.
Actually, as a matter of fact, the GATA4 at a certain point was one of our candidates there because it's also expressed in beta cells. Actually, there were some data by Jake Kushner. You remember him? That they were showing clearly with the immunofluorescence. So it might be that the severity, that you have a neonatal rather than later onset as we see, and depending on obesity as we see, instead of having this kind of phenotype, may be due to several genes that might be involved in beta cell physiology that are missing at once.
Definitely, this is a very high probability. I think that all the genes which are located in this interval, which are expressed in the beta cells, are affected somehow. So we can say that we are not able to. We can speculate that BLK is the most important player because we are, fan of this gene. But definitely there are other genes which can generate this severe phenotype in our patient.
Wojtek didn't mention what was shown on the slides, the IPEX syndrome. And I would like to thank for cooperation because we have a case of very rare neonatal diabetes, IPEX, immunodysregulation, polyendocrineopathy, X-linked, and mutation in FOXP3 genes was identified by Wojtek, what helped us to make a proper diagnosis and genetic counseling for the family and the plan for prenatal examination of the family in the future pregnancy. So thanks to current possibilities, we really have opportunity to make proper diagnosis and try to introduce the treatment. Thank you.
This is a very good point because right now we established kind of rescue system in Poland. So all the patients who are diagnosed or have suspicion for IPEX syndrome should be referred to our lab to screen the gene FOXP3, and after that we have rescue group to start preparation for bone marrow transplantation as soon as possible, because this is the only method of treatment in this case.
Any more questions? If this is not the case, Wojtek, thank you very much.